Mr. Davis Kampamba, Senior Pharmacy Advisor. I'm also joined by Professor Lloyd Mulenga, who give us a presentation on the available COVID-19 therapies in Zambia.
Good afternoon, colleagues. Indeed, we wanted to have a discussion and very brief around the therapeutics that we have in Zambia, and we expect that these are the guidelines which are going to be followed as we manage patients who now presented in the fourth wave. And after that, we'll also look at the forms which we'll be using. And Dr. Foloshi will take us through the various forms for entry of data.
I think
Internet first.
sincere apologies, everyone. We are using our mini hub. We are having a few technicalities. We'll be starting very shortly. Please bear with us.
As they are preparing for the slides to show, just need to remind ourselves that some of these drugs which we are going to discuss are available. In fact, almost all the drugs that we need except one. And Mr. Mwale, the Assistant Director of Pharmaceutical Services, and his team are available to make sure that we have some of these drugs available to all the facilities, including the private sector. And some of those are monoclonal antibodies, and the coordination on how to access those is going to be done by the pharmaceutical the unit under pharmacy at the Ministry of Health. And at the end, I'll ask Mr. Mwale to go ahead and just highlight those which are available and how this is going to be coordinated. Mr. Mwale, so just be ready to provide information on the coordination of these molecules to the centers across the country. Just in brief, let me just highlight the where there's replication of the SARS-CoV-2. We know that the first thing which happens is binding, and after binding, you have the internalization, and with internalization, then you now have where the virus starts replicating in the nucleus, and you have formation of the various proteins associated with the virus and the new daughter virions as well getting out. Those are the ones which do occur as being budding out at the end. Now, this process is a very fast process, and as a result, there are errors which are made, and those errors, once they are made, they lead to formation of new variants, which we have seen over these past 2 years for SARS-CoV-2. But the hallmark of the disease is around the immune response to SARS-CoV-2. We know that what leads to most of the pathology is the hyper-inflammatory state, which is characterized by a lot of cytokines. And especially in this talk, what we need to look at is once you have the dendritic cells activated with the dendritic cells, they do present the antigens, and in this case, it's the SARS-CoV-2. And that presentation of the antigens to the various helper cells, like the CD4 helper cells, leads to activation of other cytokines like interleukin-6. And those interleukin-6 are the ones, interleukin-21 as well, interleukin-2. Those are pro-inflammatory cytokines, which lead to various now damage because of the hyper-inflammatory state the body finds itself in. And the response really to therapies, especially the monoclonal antibodies, and we'll talk about the JAK1 and JAK2 inhibitors, and also the Il6 receptor inhibitors, is centered around reducing this inflammatory response. And also the steroids are centered around reducing this inflammatory response. But just as well, we know that there is early apoptosis, which happens to the cells, the host cells, and this early apoptosis as well leads to lung damage and also any other epithelial cells which are affected by the SARS-CoV-2. And this inflammation, the next slide is highlighting which ones are the pro-inflammatory cytokines. We have the interferons, we have the IL-1, 6, 12, 17, 18, then the tumor necrosis factor alpha. And this leads to ARDS, and we also have a lymphopenia and also leukemia associated with that. We know that this high viral load is associated with the cytokine storm, and also leads to GIC, and inflammation also is across all the various endothelial cells. And in terms of therapeutics, again, this slide includes those therapeutics which have been there before under investigations, and also that have been approved. And in summary, the therapeutics are targeting the inflammation, and also there are therapeutics which are just targeting the replication itself. And those which are targeting the replication are the remdesivir. We have the favipiravir as well, which has been used before. Then we also have other investigational drugs, ritonavir, which is also now coming on board as part of some of the newer agents as well. we have guidelines which have looked at how do we manage these patients, and we're using the NIH and also IDSA guidelines, that we combine these guidelines with the WHO guidelines. And we know that for those who do not require hospitalization, we recommend the use of monoclonal antibodies, which we'll discuss in detail in a bit. And we do not recommend the use of dexamethasone and other systemic corticoids. Those who are discharged from hospital and those who are hospitalized as well, we recommend the use of remdesivir. And also at that point, for those who are in hospital, we recommend the use of baricitinib and also dexamethasone as well. In our country, we are combining even the two of them. And so far, we have seen some good response as well. And this, again, is looking at the severity. As I said, for those who are hospitalized and they require supplemental oxygen, you can use remdesivir, dexamethasone plus remdesivir, dexamethasone on its own. We can also use baricitinib with remdesivir as well. And we can also use the Il6 inhibitors, tocilizumab plus dexamethasone. And these are likely for those who require mechanical ventilation. Otherwise, for those who don't need non-invasive ventilation, baricitinib or tocilizumab can be used. With remdesivir, there is more response when you combine the two of them. And again, we remind ourselves with this slide on when we can use some of these drugs. It's a stage 2, which you are worried of in the pulmonary phase, where you can use the remdesivir, but also the steroids you can use during this time. Then you can use oxygen throughout this period, especially when you have the inflammatory response going on. Again, just putting another way, antivirals are useful in the early phase of disease, and inflammation, once it kicks up, you use the anti-inflammatories, and antibody therapy is better utilized in the early phase of the disease when someone has mild to moderate disease. The same thing as well, just here an emphasis is that when someone is admitted in country here, we are recommending the use of dexamethasone for those who require oxygenation, then baricitinib plus remdesivir combined as well. And you can use dexamethasone plus remdesivir. We so far have used baricitinib, remdesivir, and dexamethasone with very, very good outcomes. So far, we have had people who have had severe disease, and where we have given baricitinib plus remdesivir and dexamethasone, the response has been good so far. We haven't had any loss among those that we gave this combination. Those were really, really severely ill. Briefly, monoclonal antibodies, we hope that they will be also effective against the Omicron variant. So far, what we've been using, these monoclonal antibodies, we've seen a good response. And I won't go into much of the study details. Most of us have seen this, but what happens is these are recombinant neutralizing antibodies. They bind to the SARS-CoV-2 spike protein, and as a result, they block the attachment to the AC2 receptors. AC2 receptors, wherever they are, if it's in the kidneys, if it's in the lungs, in the GI, there's that blockage which happens. And because we are depending on blocking the AC2 receptors, that's the reason why we have to give these drugs in the early phase. There's data there which shows, of course, that the risk for progression is reduced. In the Blaze trial, again, there was no death occurring when you give these monoclonal antibodies, bamlanivimab and also etesevimab. We are now have some experience in the use of these drugs, and we'll emphasize in the few slides which are coming on how we should use these monoclonal antibodies. Another slide to just justify the use of these monoclonal antibodies. When you compare with the placebo and you look at the outcomes into hospitalization, you see that there is drastic reduction in hospitalization once you give the
monoclonal antibodies compared to those that do not get these antibodies in the placebo group. And the figure 3 there, you can see as well that the viral load is also reduced on bamlanivimab and etesevimab compared to the placebo. Why am I emphasizing on these monoclonal antibodies? Because these are the monoclonal antibodies that we have in country. And just again emphasizing on where we are, you can see that 13 fewer infections, progression to mortality as well. And also when you use in those with COVID-19 and they have more than 24 hours in acute care, again, you see that there is a reduction. This slide again is showing us time to sustained recovery when you use the placebo and also when you use the monoclonal antibodies, fairly showing that the monoclonal antibodies are really doing a job. Now, this you may not see. I'll just emphasize where we were worried of there was the beta variant, where there was reduction in the effectivity for the beta variant. Delta variant was quite responsive, and also the alpha variant. Now, the big question is, whom should we give these monoclonal antibodies? We have said those with high BMI, more than 35, because they are at risk to progression of severe disease. Then those with chronic kidney disease, the diabetics, those who are immunosuppressive or they are receiving immunosuppressants, and the elderly, largely age over 65. But for those who have more than 55 and have cardiovascular disease, hypertension, COPD, and other chronic respiratory diseases, we can use that. Then there's also another expanded category, which really we don't see much. Those 12 to 17 years of age who have a BMI high, sickle cell disease, who have asthma, and also those with congenital acquired heart diseases, you may try and give these monoclonal antibodies. Remember, 2 days yesterday, we lost an asthmatic, and this is an individual, if had reached the facility earlier, could have been given these monoclonal antibodies. And what are the contraindications? Again, very key for us to know that this has to be used in early disease. So someone who needs oxygen does not need to be on monoclonal antibodies. And there is a reporting of the bamlanivimab and etesevimab, the two of them, given in those who are on oxygen, they may have poor outcomes. And also to notice that if someone has received the monoclonal antibodies, you need to wait for 90 days before starting the vaccine series. So you have to wait for that 3 months before someone is given the vaccines. Again, in brief, what are the adverse reactions which you need to look up? There may be hypersensitivity reactions. We may have some pruritus, some fever, some headache, but fever and pruritus are the common ones. We have had very few reactions in our country here since we started giving the monoclonal antibodies. And that's the reason why we have usually epinephrine available, and also we pre-medicate with acetaminophen and also diphenhydramine. Now, these are available throughout and they can be given, and we see very minor side effects because of giving them monoclonal antibodies. Let me just look now at the procedure, and it's a very easy procedure. These drugs can be administered by nurses, the pharmacists, they can reconstitute, but even the nurses, the doctors can do the reconstitution as well. We give one 700 milligrams bottle of bamlanivimab and 2 700 milligrams bottles of the etesevimab. So we have to give 3 of these, and we give them together. 700 milligrams bamlanivimab and also etesevimab is 1.4 grams. They are administered in a single infusion bag. And what we have right now, we do not have the infusion bags coming. So it's the same infusions which we use. We have to dilute these, and we dilute these in 200 mils as the final concentration, 700 mils by 200 mils. And it can be stable for 24 hours when refrigerated, and it can be up to 7 hours at room temperature. We have the 3 of them. You add 20 cc to the 700 milligrams to make that dilution, then another 20 cc to the other 2 etesevimab. And so you have 60 mils of the total. Then you have to get these 60 mils, infuse it in about 250 mils of normal saline, prefilled normal saline. And it's that which we infuse over 1 hour to 90 minutes. But before you give that, you're supposed to turn it upside down about 10 times so that you can do the mixing. You don't have to shake the infusion bag. You have to turn it 10 times so that you can have the well-mixed infusion of bamlanivimab and etesevimab. This is just a one-off infusion. So once the patient is given the infusion, there is no need for them to come back for another infusion. And as we said, this is better than if someone has had symptoms within 3 to 5 days. Usually after a week, we do not recommend giving these monoclonal antibodies. How will we distribute? Currently, we have, I think, expiries of, we have commodities which can take us up to February, end of February. And Mr. Mwale and Mr. Kampamba will talk of the logistics on how we can access these monoclonal antibodies. And we advise that this can only be given in the treatment centers and can be given if as outpatient infusions. We also wanted to discuss with you colleagues the JAK1 and JAK2 inhibitors. So the JAK1 and JAK2 inhibitors, again, the beauty about these inhibitors, what they do is they block the pro-inflammatory cycle before you have activation of the various interleukins. So before you have IL6, IL12, IL17, you need to activate the pathway, and this activation of the pathway can be blocked by both JAK1 and JAK2. Remember, there are 4 genus kinase inhibitors. There are 4 of them, but JAK1 and JAK2 are very, very specific for blocking the IL6, which is very notorious, and 17 in the cytokine storm. And this has made, of course, has led to reduction in the inflammatory response, and it does benefit those patients that have severe inflammation. And also there is a potential antiviral activity by the JAK1 and JAK2 inhibitors. Baricitinib specifically, it inhibits the intracellular membrane proteins, the AP2, and also it binds to the G-associated kinase. It leads to phosphorylation, and this prevents any activation of the messenger RNA and production of the genes, which will lead to production of the IL6, IL17, IL2 as well, those interleukins. It has ability to also work among other viruses, Ebola, dengue, hepatitis C, and now the SARS-CoV-2. Again, this is the trial from this trial. It showed that once you give patients with with remdesivir is better reduction if you give the steroids as well. It was compared to those who are given with steroids and remdesivir, and the response was much, much better. However, there is a new trial which has combined the remdesivir and the baricitinib, where you have better.
Recording in progress.
You may not see these slides just over this, the response, but you can appreciate briefly that those which were in red are the ones which were the patients who are on baricitinib, but you can see the mortality. You can see that the rate is lower. So when you see that the rate is lower, it just means that the rate of mortality is reduced for those who are on the who are taking the drug represented by the red line people baricitinib.
Once we say the central to pay the authority or get other parties to the end cost or sure.
Corresponding to 38% reduction in mortality. Again, emphasizing the need to use. The FDA has recommended its use, and this one is not an IV drug, it's an oral drug, so we can use it even for pediatric patients. You can cut it into 2 milligrams orally once daily from 2 years to less than 9 years. Above 9 years, we use the same dose as the adults. However, we have to do a dose adjustment if we have to give those that have a kidney disease. Serious contraindications will be those who have serious infections, and these also if someone has active TB. Remember, we are giving an immune modulator, and even those who have thrombosis as well. You can just have to be careful and monitor them as well. Vaccinations, use of live vaccines. So use of live vaccines also has to be avoided with baricitinib. You need to monitor the liver, the kidney, and also the blood profiles, hematological values for someone who is receiving the baricitinib. I'm sorry, the slides seem to have. So which are the special populations? Pregnancy, there is limited data, but we know very well that we can use. We can use this molecule as well if you think that the benefit justifies the risk to the mother and also the fetus. No studies over hepatic impairment. Really, we do not recommend for those patients who are on dialysis with end-stage renal disease or AKI, and also those with GFR less than 15 mils for those more than 9 years, and for children where the GFR is less than 30 mils per minute as well. So really the major contraindication which we have here where we need to observe cautiously or do the dose adjustments, those who have kidney disease. And these are the recommendations if you have to do the dose adjustments if there's someone with renal impairment. IDSA, it recommends among those who are hospitalized with severe COVID-19 and you have high inflammatory markers. It's a drug which IDSA recommends for use, and we also have recommended its use. This is the same on IDSA recommendation, and this is the suggested criteria. Initiation, if someone EGFR is more than 15, they also have absolute lymphocyte count more than 200 and the neutrophil count more than 500, and someone requires supplemental oxygen, or they are not receiving dexamethasone on any steroid due to contraindication, this is a drug which you may give. And as I said, for us, we have used even with steroids, and we have not had any worse outcomes so far. You need to monitor the patients closely. Then these drugs can be given for up to 14 days or until given 7 days and they are discharged. Then you can stop. If someone is in the hospital for 2 weeks, then you can end at day 14. If the lymphocyte count drops to less than 200 or the neutrophil count drops less than 500, then you may need to interrupt therapy. Briefly, let me talk about the Il6 receptor inhibitors. This is a drug which we may have possibly during this fourth wave. We don't have the Il6 receptor inhibitors. And again, what the Il6 receptor inhibitors do is by blocking the signal transduction, and it is similar to the JAK1 and JAK2 inhibitors, and as a result, they calm the inflammatory storm. Remember, the JAK1, JAK2 inhibitors, they prevent even the activation of Il6 cytokines. So they act at an earlier stage compared to these Il6 receptor inhibitors. Tocilizumab is one which we are really likely to get, and we see that mortality is reduced for those. In this case, they are not in red. The one which you can see there in green, that is the tocilizumab, where you see there is reduction to ventilation and also death. And similarly, also the days from admission over time, you see compared to the standard of care, there is a reduction to both ventilation and also mortality. Again, looking at from another angle, you can see this slide which is presented here. If you look at those individuals who are on tocilizumab, this is better, and then also the control. You can see that even those with C-reactive protein more than 150, they perform better when you look at death or even ICU compared to those individuals who are on the placebo, or which is the control group here. For those whose inflammatory response was not high, of course, the placebo does better. And again, this is why we recommend the use of tocilizumab in those with severe infections whom you don't want to be mechanically ventilated, or those who you fear may die, or you fear may go to be on mechanical ventilation. And again, for those on mechanical ventilation, you see as well that the survival was better if given the tocilizumab. WHO also does recommend treatment with the Il6 receptor inhibitors, the tocilizumab or sarilumab, and we are considering tocilizumab in our use. I think I'm confident that we are likely going to have tocilizumab as well, possibly in the month of January, before we end this fourth wave which has just started. These are the highlights, and again, I need to say we have baricitinib, and we also have a monoclonal antibodies, bamlanivimab, and also etesevimab. I now hand over back to Dr. Foloshi for a short discussion before we go to look at the forms which we are going to be using. Dr. Foloshi, over to you.
Professor Lloyd, thank you very much. We have been joined by Chiwa, who is the pharmacist here at UTH, who's been supporting us with administration, along with Dr. Patel Uchizi, are you able to run through the paperwork that's needed for these drugs? Uchizi? Just to mention that the monoclonals will come with these papers that need to be filled in for every patient. This is for purposes of accountability and having data for our own population in terms of outcomes and response to the monoclonal antibodies, as this is the first time we are using them in the country. Uchizi?
Okay, Uchizi seems not to, once she indicates that she's connected, we'll definitely call on her, seeing she's on the ground, of course. So this is one of the forms that is being used, like earlier mentioned by Sombo. As we get these monoclonal antibodies, we are supposed to get these forms as well, and facilities are encouraged to print, even locally. These forms have been shared with all provincial pharmacists and the pharmacy leads that are within facilities. So like it was mentioned earlier on, it is very key for us to just keep track of the things that are indicated here, so that even as we track post-market surveillance in terms of side effects and all, and as we report to ZAMRA, we are going to notice those things that are new that the patient would have not been presenting with as they came to the hospital. So many of these are as we capture them in other admissions, but we need to make sure that we populate these things as shown here. There's also another form that actually tells you on what Professor was talking about, and I'll speak to that just a minute. Of course, this will be filled in by the attending physician or clinician. So just a minute, let me share another form that will also guide you on the dilutions that Professor was talking about, just in case you forget what has been mentioned.
In the chat.
So this gives you some more details, as can be seen, the little criteria that is here. And as it was earlier mentioned, for the monoclonal antibodies, we're giving those that are 12 years and above, or in terms of weight, 40 kgs and above. So if one is less than that, we do not give. And as can be seen, weighing less than 40, we do not give. So this is different from the baricitinib, which could be given to someone who is 12 years, 2 years and above. And of course, even for TB, we're not giving these such clients. So this is just giving us the details. Okay, what time the preparation of the infusion was done and the time recorded there. Remember, we're supposed to use this the preparation within 24 hours. Beyond that, we simply discard. So it is very key to follow this. And then for the pre-medication, one of the side effects or adverse effects that one may get, things like fever and all. Okay, so of course we see that paracetamol is given before we give the BAM and ETE, and the time recorded as well. And even as we start the flow or the infusion, we record the time. So it's quite self-explanatory, as can be seen. Even the heart rate, the BP, the respiratory rate, and all that are all recorded. And this is a table that now clearly gives us the dilutions and the infusion rate, depending on how much fluid we added. And of course, if we give this one the 250, then using that infusion rate, it means that infusion will last 60 minutes. Okay, so that is one of the forms. And like we said earlier on, these forms are supposed to be printed, and each facility that will be collecting these monoclonal antibodies is supposed to make sure that these are printed, and pharmacy make sure that we are in custody of this, so that every time we dispense, these forms are given at the same time with a drug. Now, like we said earlier on, it's a requirement that we take note of how the patients take this. So it's not like we're always looking out for side effects or bad outcomes. So even the good ones we still need to report. But how are we going to know about the good outcomes if we do not record? So that is very key. So the side effects we record, the patient takes it very well, we still record and we report, because that's how these drugs will widely be rolled out, actually, should we score great success. Let me also just share another form, and with that I'm probably going to end.
Admission.
We can.
Go ahead. Go ahead.
Okay, so we move, like we said, we'll share these forms. We move to maybe the admission form and the follow-up form. Let me just share that as well. And Dr. Follow, she will run us through. Just give me a second.
Please note that we will share these forms with the rest of the network for use in the various facilities. We were prompted to develop a COVID-19 admission form following feedback on one. We don't have enough data on how we managed our patients in the previous waves, and also because we are using a paper-based system, we noted that there was a lot of variation in information, so we wouldn't know the oxygen devices that were being used and how much oxygen was being used on our patients. And this has impacted our ability to actually plan for our surges. So this is a basic form. We are still revising it to make it friendly to the clinician. Please note that it's only the first form that requires a lot of information. The subsequent form, if this is well filled in, is very easy to manage. Among the highlights, the importance of screening for tuberculosis in these patients. As you noted, some of the drugs are actually contraindicated in people with active TB, and that drug is baricitinib. So all patients that are admitted to the ward need to be tested, screened and tested for TB. Furthermore, we have gone on to have this form be put on a one-pager that will be hard and will act as a file. So it will not be the soft paper, it will be hard. There's a follow-up form that has to be filled for every patient. So for facilities that use electronic systems, we will be more than happy to share this with you, and then you can enter this electronically. But for facilities that use the paper-based system, we have come up with standard forms that are simple. So this form is basically a continuation sheet to allow us to have accountability, but also for completeness of forms and data on our patients. For one, to help us do better as we progress with this pandemic, but also have enough supplies in our facilities. So this form will be on an A4 soft paper and is expected to be entered from day 1 of admission, because day 0 will be the hard form. Please remember to always fill in the date of admission, how long they've stayed on the wards, so that we can enhance our data. Data clerks and data quality officers will help us ensure this happens. So this has been kept very short to allow for clinicians to have enough space for free text writing. Please note that on the back of this form, it's plain. So if you have more to write, it can be moved to that place. There is also a form that has to be filled in for vaccines.
Yes.
This is because as the pandemic has evolved and we have noted the development of variants, we have had to track our population's response to these vaccines. So in terms of vaccine effectiveness, so there's a form that each hospitalized patient has to have, and that captures the types of vaccines, the date of vaccines, and this will also later inform our policies on booster based on the patterns we see in our clinical area. Dr. Chanda, would you like to comment about the vaccine? So this is the vaccine history. This will be filled alongside the admission form. It will come as a soft type of paper. Of course, for facilities that use electronic systems, this will be filled in electronically. So this is just to help us have better data, because we are really struggling with data from facilities at the moment, including ourselves here at UTH. So we hope we can have more information on our patients, how our vaccines have worked in these patients, and how we are screening them for TB. At this point, we'll stop sharing our screen and allow for questions. We'll start with some that may be in the chat box. Mr. Mwale, please go ahead with your contribution.
Thank you, Prof, and also thank you, Dr. Folosh, for facilitating. I think for us is just to also take note that I think COVID has come with new knowledge, and which we should be very ready to learn. I think some of the drugs that have been mentioned, some of us are hearing them for the first time, approved just recently, and what it is that all of those forms that have been mentioned, some of them are to take care of the requirement by the regulator that we need to take note of the development, and not every side effect has been documented, but you will help to document every side effect that is and even adverse drug reaction that has been observed. For distribution, and Mr. Kampamba will go through the distribution, but what we have done, I think all the provincial pharmacists have had I think we've had a chart regarding the allocations for bamlanivimab, cemiplimab, and also baricitinib. So all of these drugs have been shared, and what will be very, very key, because they have a short expiry, I think we need to maximize the benefits from these drugs that are quite expensive but available and can be used. And I think we need to obviously make way to come over to UTH and collect your shares. I think most of you should know by now that you have a distribution list and you could collect. One thing that we also need to know that the two drugs also need to maintain, we need to maintain cold chain. So you need to come with cold chain equipment also to collect these drugs. I think that maybe Mr. Kambamba can add on the distribution, and if there's any particular item I've left. But otherwise, I think those are the key issues that we need to do. Itemize the related adverse drug reaction that are related to the new drugs. The protocols related to new administration of new drugs, I think, need to be applied. We learn more in terms of the side effects, adverse drug reaction, and how we can mitigate for them. Over to you.
Thank you so much, Mr. Mwale. So as mentioned earlier on, a distribution list for these monoclonal antibodies and the baricitinib has been made and shared with the provincial pharmacists. And we are glad to, of course, see some of the private sector that help in the management of COVID-19 patients. Please, these for use, the bamlanivimab and etesevimab, including the baricitinib, for the patients that we have in admission for free in our facilities, including those created private facilities that we usually report on in our daily updates. So these can be gotten from the provincial health office for those that are in the outskirts, and of course for those that are within Lusaka. As we have been getting other commodities, please feel free to get in touch with us, and these commodities will be made available for the patients that we need. And that is why this presentation by Professor and the use of the forms were very, very key, so that even as we get these commodities, we know what to do and how to use them. Thank you so much. I'll hand over to Sombo just to respond to some of the comments in the chat box.
I'll allow Joseph Kongolo and Nawa Kalima to go with their question. Joseph and then Nawa and then Justo, then we can have responses. Kongolo?
Good afternoon, Dr. Foloshi. Thanks very much for allowing me to ask my question. I have a couple of questions for Prof. The first one is the management of the patients which he presented. I presume this is the management of patients who are unvaccinated. I don't know if I'm mistaken, but is there any change of management if this patient presenting with COVID and has been fully vaccinated, in terms of considering giving the monoclonal antibodies or not? That's the first question. And the second question, the network was so bad and I did not get properly the clear indication of these monoclonal these monoclonal antibodies. So I don't know at which period of the disease this drug should be given. Thanks very much.
Dr. Kalima, please go ahead with your question. Then we'll allow Justo to ask his question. Then you will get responses. Now,
All right. Thank you very much for the presentation. Quite informative. I just have two questions. The first was concerning the vaccine history form. I noticed there are a couple of questions which relate to the date at which one got vaccinated and so on. Does it mean that clients will need to move with their vaccine cards if they're going to get attended to, particularly at the COVID center? Or do we have access to an electronic database where we can easily check the date of vaccines and what type of vaccines they received? Then the second question is more in line with what you said, the lack of data. I was just doing my own kind of reading and research, and I find it's quite hard to get data on Zambia other than that which is reported maybe by WHO. How can we locally collect data? Is there a website that we can go to where we can look at our statistics, particularly pediatric statistics or age aggregated statistics or sex aggregated statistics and so on? I submit.
Justo, please go ahead with your question. Thank you, Dr. Nawa. Justo, please go ahead.
Thank you for the good presentation, Prof. Mulenga, and basically the other presenters. So my question is, the monoclonal antibodies, they're basically targeting the people that are with mild symptoms. So meaning that if you're employing a triage system, these are basically yellow patients, meaning that they're actually found at a lower level of care. While with the severe patient and the critical, they're the ones that are being triaged to actually a higher level of care, meaning that administration of these drugs will be at a lower level of care. Which brings me to the second question. Assessment of the length of stay is an assessment of the time, basically to outcome, which is mortality and so forth. So meaning that the inpatient assessment is actually done at a higher level of care. So I need to be clear that I was saying that all the yellow patients that at the primary level have to be now triaged to the higher level. That's my question.
Thank you so much, Dr. Justo. So the first question from Dr. Pongolo, what is the eligibility of people that are fully vaccinated when it comes to monoclonal antibodies? The second question was on vaccines. The vaccine form, will we need NRCs for patients who are hospitalized? And then that Dr. Duncan will take that one. And there's a question from Dr. Justo. I hope I understood this. Monoclonals are for OPD, essentially. Yeah, exactly. So meaning primary healthcare can do this. And we are looking for outcomes. Are we saying most of these should end up at a high level facility because of this outcome of interest?
I can handle that. Hi, I hope you can hear me. Or should I come back? Are they here? Mm-hmm. Am I audible? Yes. All right, thank you. Dr. Chanda here. Let me first respond to the issue of vaccines and whether the patients have to have their cards or to remember the dates. There are various ways of doing it. Indeed, if the patient came with the card, that would be straightforward. If the patient is able to recall, of course, we know it's very difficult sometimes when the patient is critical. We're not going to do it at that point. Then the other issue is we have a centralized system, electronic system, which keeps this data. So we need the patient's NRC, and then we can retrieve that data. Clearly, that's not urgent, but it has to be done as we are in contact with the patient. Dr. Justo asked a question around monoclonal antibodies are for relatively well people who are primary health care. That's correct. But then if you look at the guidelines, even from WHO and European guidelines, there's an encouragement that these monoclonal antibodies are actually administered in centers specifically to do that. Here at University Teaching Hospital, people might be aware we have a COVID outpatient clinic. Pretty much, I know a few other centers which have set up this kind of clinics. Yes, Justo, you can identify these patients, for instance, can be identified from other areas of Lusaka and then sent to our COVID outpatient where we can actually administer this. We are all learning as things unfold, but realistically, we cannot have this being infused in all the primary health centers, for instance, 10 in Lusaka, because we need to monitor them and we need to be strict about who's going to get this. And then in terms of outcome, good point. So we've got, we've got phone numbers for these patients. And we are phoning after a week for those who have gone home, and then we follow up there. Sometimes we get patients or families who are going to call in to say this patient got a monoclonal and we have got this problem or this side effects. We still expect if someone is admitted, the family or the patient themselves to alert us. We still expect through our surveillance of getting in touch with families and the patients that would know the final outcome, let's say about the 28th. I hope that helps to answer some of those questions. Some students.
The length of stay.
Yeah, that's the one I just answered. Yeah.
Professor, for the people that are vaccinated, are they welcome to get monoclonal antibodies?
Yes. Yes, so even those that are vaccinated, the criteria is the same. They are welcome to get monoclonal antibodies. It's remember the issue is here, it's those who are at risk of progression.
Yeah.
We know that, of course, there will be some effectiveness, but right now, when you look at the data on vaccine and also progression, and that is the more reason it's tied in even to the booster. So it's the same principle just to be applied. So even those, if you have someone who is vaccinated, but as those at risk of progressing to severe disease, yes, you need to.
So of course, those that are vaccinated, their risk is less. And these risk factors are cumulative. For example, if you're hypertensive, diabetic, obese, even if you're vaccinated, we recommend the monoclonal, isn't it, Professor? Because they are additive.
Yes, yes.
There are some more questions here. There was a comment on the use of remdesivir. The World Health Organization has actually put a recommendation against remdesivir. Is there any reason why we are still using it in our setting? And what's the compelling evidence why we have maintained remdesivir?
Again, very good question. Where we are divided. Dr. Chanda sits on the WHO body. And again, you have to look at the WHO. It's a conditional recommendation. A conditional recommendation puts in line with how much the resources you have for you to spend on such an expensive drug with the data which is available. And also, when you look at the combination therapies as well, remdesivir has done well when you combined with Il6 inhibitors, when combined with JAK1, JAK2 inhibitors. And we also have local experience where we have seen, especially those that you give in early disease, they have done well. So it's based on these factors. And I'm sure, you know, in WHO guidelines, when I'm making the guidelines, it's a guide to a public health approach. And you can see that some countries, they do not follow if they have extra resources, and resources is one big issue which is considered in the WHO guidelines. So that is the reason why we have maintained it.
Thank you so much. I'm sure you're aware that the team uses other guidelines aside the WHO. So you may see some things that contraindicate, because we are also doing our own literature review. Dr. Mwale, Edo, please go ahead with your comment?
All right, thank you very much, Doc. Thank you very much for the presentation once again. My question is just on the distribution of the drugs. So firstly, for example, I think, of course, we are going to be seeing a bit more numbers when it comes to the treatment of these patients. Are you open to more facilities joining in terms of treating these patients, especially the fact that most of these are outpatient, basically patients? So are we open to getting more facilities to come and join in terms of administration? Secondly, also, what determines what quantity each facility gets? Does it determine or depend on the number of patients, COVID patients they see? And what data, for example, if a facility wants to join, what data would you want them to come and present to the team to see if they could be considered to be a vaccination, basically a treatment center in this case, basically in view of the monoclonal antibodies that have just come in?
Doctor, the ministry looks forward to having more centers open for management of COVID infected individuals so that you can lighten the burden on the government. We have an assessment criteria for the facility, which is considering admission of these individuals. And what you just need to do is just to send a letter to PS requesting for assessment of the facility. So once it's assessed, then you'll be able to have access to all the medications which you are talking of, those which are not available in the private sector. That is the procedure, Doctor. We are looking forward to having more centers open up. Remember, the burden is so big. The public sector cannot manage, and we need to thank the private sector which have come up. We have seen a lot of relief in Lusaka because of the private sector, and we are encouraging more players even in this area. Thank you.
Thank you so much. There's a question on steroids. The recommendation remains the same. We do not recommend steroids for patients who are in the outpatient setting, bearing in mind that we've added TB screening because we are aware with our high TB prevalence, we may have activation of TB. Professor, there are some questions regarding the booster. Are you able to update us? I'm aware these are two separate sessions, but healthcare workers are, I think it's Dr. Siyolwe, healthcare workers would like to know more about what our position is in terms of booster, especially that there is data on booster being better for Omicron.
Apparently.
You're asking me. It's not the audience asking. It's
No.
It's not the question. The question.
I thought it was Dr. Folosh asking me such a difficult question. Colleagues, yes, we have been discussing the issue of the booster. In fact, right now, there is a meeting. I'm supposed to join a meeting for the ministers considering this. We have recommended the ZITAG, which is responsible for all the regulation and coordination of the vaccination, did meet twice last week. And that recommendation was presented to us yesterday in the afternoon. And the small committee within the ministry and also the State House also did come up with what we need to consider. And this has been now thrown to the Council of Ministers, which is about to start meeting right now to consider the issue of the booster. We just need to say that it's a matter of time. I think boosters will be given. Likely policy will come out. If not today, then this week we should have policy guidance. Thank you.
So, Prof, may you please indulge me? There is a question regarding the circulating variants in Zambia at the moment. We are aware that the third wave was mostly driven by the Delta, while we did have 3 reports of Omicron isolated in Zambia or sequenced in Zambia from patients who are in Zambia. Do we have any more information on this? And can facilities submit samples for sequencing? What is the procedure?
Yeah, so
right now, almost all those that is being sequenced, it's the Omicron which is coming out.
Yeah.
Since 3 weeks now, we haven't seen any Delta or any variant, including the ones which were released today. They are all the Omicron. It was all the Omicron variant. The ones which were released this morning, I think there should have been 46 or so. So with that, 54 rather, sorry, with the 54 from talking of Lusaka, 47 Ndola, Kasempa, Kitwe, Mfulira. So it's widespread, it's the Omicron. As a result, we are saying that the driver of this current wave is the Omicron variant. Genome sequencing will continue. Yes, we can send to the ZNPHI, the UNZAVET, and also CHAS, but we also have on the Copper Belt, TDRC, and also MACHA and the UTH. These are the 6 labs now where you can do the genome sequencing. However, I need to say that once you have an established variant as it is, there will just be now sampling of which populations are we going to be looking at. Otherwise, we cannot manage sequencing everyone, because right now we have a picture that the dominant variant is the Omicron.
I hope that's helpful, Dr. Kongolo. And please note, right now we are focusing on the hospitalized patients in terms of sequencing for purposes of management. And that's far what we have is Omicron. And based on our study from July 2020, our data is available, but estimates are usually larger than what we report. And this is actually uniform across the world. It's not only Zambia. So it is safe to say that the dominant strain at this point is the Omicron. There is a question from Dr. Constantine Malama, which I really like. Is there a possibility of reducing the age at which people can be vaccinated? There are parents who want their teenagers vaccinated.
Yes, my brother, Costa, yes, there is such a consideration. It was also considered and it's part of those which are being discussed. The age to start from 12 and above, but that to only be for the Pfizer. The rest has to be maintained at 18.
Okay.
So, Prof, before people actually misunderstand this, in terms of monoclonal antibodies, remember the BLAZE-2 trial actually used
seronegative.
They used seronegative. So they used the monoclonals, BAM and ESTE, as post-exposure prophylaxis, especially in the homes of the elderly. And obviously, we have such scenario as well here. What's the guidance from the ministry on that kind of scenario? Because we'd like to be clear. Some people might walk up and say, my children are positive and I'm 80 years. Can I get a monoclonal antibody?
So the policy is how to implement. So we are not measuring.
Does this one? Yes. Okay, sorry.
Yeah, so we are not measuring the status of someone before you give antibody status before you give. Ideally, it would be, but it's not feasible. So it's anyone who is just at risk of that progression. That's where we are giving that.
Okay, so there's a question. I think this is a very difficult question, Professor, and you did present a slide regarding this. In terms of variants and their responses to the monoclonal antibodies. As we are aware, COVID-19 is an evolving science. The question is, how effective are these against the Omicron? Bamlanizumab and Itasimab. Should we be looking at other monoclonals, bearing in mind the cost and the sequencing data?
Our colleagues, we don't have that data. In fact, it's even very difficult for us to prove that this will be effective with Omicron or not effective with Omicron. We need then to design a trial around that. So can we
Personally, I do not think that we need to spend a lot of resources getting for the monoclonal antibodies, because remember, these are mostly useful during a wave. We need to invest more in vaccination and also possibly in boosters as well. We saw, of course, for the Delta variant, there was effectiveness, but for the Beta, again, we saw that it was not effective. We don't have that data yet.
Yeah, definitely effective against Delta, which was surprising, but ineffective against an earlier variant. That is why it is very critical that the data is collected and even the outcome data using phone calls. There is a question here on just an update. We have, for those that are admitted, how many of these actually are vaccinated? What are the proportions? What are the numbers looking like of vaccinated versus unvaccinated of those we've hospitalized so far?
So far, we collect routinely the number of individuals who are vaccinated and those who are being admitted. We have seen that the admissions are largely those who are not vaccinated, should be possibly about 10% of the vaccinated. And again, even those that are vaccinated, there are those who may have risk factors. We have those that are fully vaccinated who've been admitted. But in terms of mortality, so far in this wave, we haven't lost one who is fully vaccinated. Again, some encouraging news. We had the study again where we looked at all those that were vaccinated, and the risk, the chance of having a mortality for those people who are not vaccinated was about 28 times higher compared to those who were not vaccinated. Again, that's the local data which we have proving that at least for the Beta variant, that vaccination was very, very helpful. We don't know for the Omicron variant if it's going to be how it's going to play. Thank you.
Thank you very much, Professor. Regarding sequencing, for the past couple of weeks, we've been sending samples from both OPD and inpatient. What is the current guidance? Should they only send from inpatient and not from OPD? For sequencing.
Yes, so for genomic sequencing, yes. Now we are looking at the inpatients.
The inpatients. Just
and there will be once in a while when there will be again sampling at intervals. You sample as things changed over time.
Yes, and bear in mind that the sample that's used is the same PCR that you send from OPD. So this is actually done at lab level. Professor, we want to thank you for your time, Dr. Duncan, and Mr. Mwale, Mr. Davis Kampamba, and I see Uchizi joined, who has helped us a lot with this. Just to mention that we actually have gone into recess for the ECHO program, but in view of the fourth wave, we will remain open as this is a rapidly changing issue. So thank you for joining us and thank you for your time. We will communicate if we do have another ECHO during this recess. Thank you.